Hello and welcome to Read Scholars Live. I'm Dr. Mary Fleming, your host and current president of Read Scholars. Today we are joined by Dr. Edmondo Robinson. Dr. Robinson currently serves as the Senior Vice President and Chief Digital Innovation Officer at Moffitt Cancer Center in Tampa, Florida. He received his medical degree from UCLA, completed his residency in internal medicine at Harvard UCLA, and holds an MBA from Wharton and a Master's in Health Policy Research from the University of Pennsylvania. Prior to this position, Dr. Robinson served as Chief Transformation Officer and Senior Vice President of Consumerism at ChristianaCare in Wilmington. In this role, he was responsible for the transformation of healthcare delivery to advance population health initiatives and move from the volume-based to value-based care. And he has done lots of wonderful other things that we'll talk about in the course of this conversation. Welcome. Thank you for joining us.
Thanks, Dr. Fleming. Appreciate you having me on.
Just because it's this time, just a quick check-in. How are you doing? How are you coping with personally with the COVID pandemic?
Yeah, it's thanks for asking. It's been a challenge, of course. It's a challenge for lots of folks, right? So, just personally, it's work from home. I got, our team was able to get, over half of all of our team members at Moffitt working from home. So we're kind of Zoom experts at this point, in terms of working from home. We're doing a lot of that. Families safe and in quarantine, not just kind of self-isolating. And so, it's a blessing to know your family's safe. But you also see so many folks out there who are dealing with this, and you just want to figure out ways to help and contribute. And so a lot of what we're spending our time doing is figuring out how to do that. And what does that mean? What is our role in terms of being healthcare providers? How are we contributing to ending this pandemic? And so, from a public health, from a direct service delivery, all of those things, those are top of mind. Once I'm confident my family's safe, that's really what we start thinking about.
That makes a lot of sense. And I think for, especially in leadership, trying to figure out that transition of work from home can be especially challenging as well, too. And I know a lot of people talk about the work-life balance, and work-life balance before means something different when you're at home with your family and the kids and that type of thing. So I know it's been a little bit challenging. So I wanted to talk a little bit about your transition, because I know you're new to Moffitt, and it's a new leadership role for you there as well. But you've had very interesting positions as a physician in the leadership space and in the technology space as well. Yeah. So can you tell us a little bit about how you initially got interested in the digital technology space? And
So I started my career off maybe more traditional in terms of physician leadership, involved in the medical group, starting a practice. I'm a hospitalist, so I started a hospital medicine practice, had some leadership roles within the medical group, and then ended up having some leadership roles within the health system as a whole, in terms of being a physician in chief and being an associate chief medical officer. So that's pretty typical in terms of physician leadership. And then I went on sabbatical in 2015. And during my sabbatical, although my first thought was I'm going to go surf in Hawaii. That's what my first thought. So that didn't happen. I probably would have gotten bored anyway. So what I ended up doing on my sabbatical instead was being wide open. It was an opportunity to just put all my preconceived notions down, being wide open. And my question broadly was, where is innovation in healthcare going? In healthcare delivery specifically, where is it going? I wanted to kind of the whole idea of skating where the puck's going to be. And so I spent half of my sabbatical in Silicon Valley and half of my sabbatical in the UK. And my thought was, let's follow the money first, right? So, all this investment's going on in healthcare innovation. Let's follow the money. Let's talk to thought leaders, investors, a lot of founders, and let's just understand what they see as opportunities in healthcare innovation. And then I juxtapose that with how they're thinking about healthcare innovation in the UK. Obviously a very different system. It's capitalized differently. And obviously in the underlying kind of core structure is different. But my thought was that if I could find themes that were consistent across those two experiences, then that might be, although I'm not a fortune teller or anything like that, but if I could find those themes, I would think, you know what, they might have legs, and I might be able to, that might be where we should go. And so that was my goal. There were several themes that I pulled out of them, but one of them, really importantly, was the role of digital. Remember, this is 2015, so digital starting to kind of come along, but it wasn't, digital health as a thing. Physicians with digital titles in health systems was not really a thing. And so when I came back, I didn't have a digital title either because it wasn't a thing. The goal was to transform, was to go from one way of doing things, as had been done for decades before, as you know, and figure out what the future holds. So that's why my title was transformation. Ultimately, it became very clear that building out digital was going to be a core component of the transformation. So I spent a lot of time building out digital. And I also had the consumerism role because that was another theme, was the importance of consumerism. And I ended up combining the two and actually had consumer digital as well. So even though my title wasn't transformation, my title wasn't digital, even as a chief transformation officer, digital was really critical to what we were doing. My thought on digital, I wasn't an engineer in undergrad. I'm not really a technically trained person in that way, in any way. My thought on digital is this: digital is a means to an end. What we're trying to do at Moffitt, for example, is we're trying to cure cancer. It's prevention and cure of cancer. Digital is not the end. Digital is the means to get us to prevent and cure cancer. And so I think about technology in that way. And so I think about it strategically. And so because I come at it with a different perspective than maybe someone who came in from the technology space. So that's how I got there. But I still think of it that way. I love the technology, don't get me wrong. But at the end of the day, what are we trying to accomplish? What's our strategy and what's our mission? And how do we leverage those tools to get us there?
That makes a lot of sense. And you are quite the visionary, I think, in that regard, because, as I mentioned, we were talking briefly, your job titles are quite unique. And so I think helping us think of ourselves as physicians and as leaders in a different way helps to push what our capabilities are within the healthcare system. And so one of my other questions, so your job at Moffitt is slightly different than your job at Christiana, right?
Yes.
And so Christiana is a huge healthcare system. It serves a very unique, well, maybe not unique is not the right word, but it has a large underserved population, some vulnerable populations, right? And so Christiana spends a lot of time around improving population health, or has, I think, recently. So can you speak to a little bit about that part of your role there, and then transitioning to how your role is different, because Moffitt is different. So as you mentioned, the Cancer Center, and how you anticipate. I know you're still transitioning, but how you anticipate that differing for you?
Yeah, it's a great question. So at ChristianaCare, I had multiple different, as you mentioned, I had multiple different roles. One of them was essentially it was executive director of the Wilmington campus. So the Wilmington campus, Wilmington's the largest city in Delaware, and so if you're looking for, where you're gonna, where's a hot spot around disparities, Wilmington would be one of those, at least in that primary catchment area, that primary market. And I served as the senior executive representative for ChristianaCare within that city quite a bit for quite a while, actually, because I had that role from 2011 on. And so you see firsthand, I literally walked the neighborhoods, talked to the community leaders, the religious leadership, and, the city council and the mayor and all of those. You just got to be in there. And once you're there, and you're seen as someone who's actually there to help. You're not just there kind of going in and, so you got to form that bond and that connection with the community. it's kind of the core of one of the things I learned in fellowship was community-based participatory research, right? And like part of that core is that there's got to be you got to build some trust, and that trust has got to be earned, right? So you get in there and you go earn that trust. So that really important part of my role. So I would be involved in community organizations. I would be on the board of some of the kind of community organizations there. I was on the board of a local school that was supporting underprivileged kids, underprivileged youth in middle school, and really getting them into really great high schools and colleges and so forth. So just being there, being a part of the community was part of my role there. So yeah, we can talk digital, and I still see patients and doing publishing and teaching and all that. But at the end of the day, also you needed to make sure that you were a core really in some ways a corporate citizen, supporting the city, and I took that role quite seriously. And luckily enough, a good friend of mine who is still at ChristianaCare is going to step into that role, and I think really going to continue that the important connection with the community and supporting the community and what their needs are around disparities. He's actually much smarter than me, and actually is a disparities researcher. So they're very well off there. Switching to a cancer center, and like you said, Dr. Fleming, I am still transitioning. Cancer centers are such different beasts, especially an NCI designated comprehensive cancer center. There's only a handful of them. If you think about total cancer care across all of the country, there's only one comprehensive cancer center in all of Florida, and that's in Tampa, and that's Moffitt. So you think about, but you think about the role of a cancer center. The catchment is just massive. I mean, people are coming from all around for the kind of care. You've got specialists who are literally the best in the world at what they do. And so people come from all over to see those people. That being said, I had a very great conversation with Dr. Susan Vetter-Parampil, who's responsible for health equity in cancer care at Moffitt. And she, on the research side, right? Because you think about big cancer centers, they have, a core big chunk of what they do is research, and then of course there's the clinical care and education. And addressing disparities, focusing on equity is still critical in cancer care. It's really critical, and the National Cancer Institute is calling these cancer centers out and saying, "Hey, you have to build a program. You have to address this, and that has to be part of your grant application to be part of the NCI." So it's a big focus. And we had the conversation that I had with Dr. Vetter-Parampil was around how can we leverage digital to help? How do we leverage digital to understand the community? How do we leverage digital to reach out, to engage, to even diagnose and treat? And so there are quite a few opportunities there. It's a different lens that I have to put on in this role. My role at Moffitt, I'm responsible for all of IT, for example. I have all of IT. I've got health data services, so all the operational data, how the data flows back and forth, and we've got innovation. We've got to build new things. Right now, I have really smart people that are doing that. I have a brilliant CIO. I've got a brilliant chief data officer. So it's not like I have to do this, on my own. I've got a wonderful team. But that's the scope of what I'm responsible for the Cancer Center. And so it is a transition, but disparities and really addressing and having the role of health equity in cancer care continues to be front and center.
And one more, I guess, to push that one more step when we talk about digital health and health equity specifically. I know a lot of the conversation now is as we build out these digital platforms, how to make sure we're not introducing new barriers, right, when we're creating these new digital platforms, but also how do we, and this is the harder thing, but how do we not perpetuate systemic racism that's already in the system when we're creating these systems, if we're just taking the system that is in place and extrapolating it, right? So any thoughts on that? I know those are a little bit.
So many thoughts. So many thoughts. So first, I think we have to make sure we are not assuming that technology will solve those challenges that you just mentioned around systematic racism. It's just systemic racism. It will not. If you do not address the system, technology will exacerbate the biases that are baked into the system. So that needs to be understood from the get-go. Okay. It will. And so therefore, just as you have to be disciplined in figuring out how to address, for example, bias in any delivery system, you have to be just as disciplined and maybe more to address these issues when you use digital tools. You have to specifically call it out. You have to write that out. For example, think about artificial intelligence. Part of the challenge with AI is that it's a bit of a black box for a lot of folks. They're like, oh, some stuff goes in, some stuff comes out. But here's the problem. Folks are just trusting that what comes out is the truth. There's algorithms in there. It's not necessarily the truth. But the thing is, we've been trained, you've been trained, I've been trained, we've all been trained around, say something like hemoglobin comes back. When one of your patients, their hemoglobin comes back. Now, their hemoglobin may be not exactly what it said. There's a margin of error, and if you checked it tomorrow, it might change. It has nothing to do with actually anything that happened with it. You know that.
Right.
We don't have the same understanding of the margin of error around AI that we do around all the other tests and all the other implementations and all the other innovations that we do. Right? And that's a challenge. So now it's almost as if you got that hemoglobin and it said 6 and you were just like swearing it could only be 6. There's no other way it could be anything else. That's how we're treating AI, right? And we cannot do that. We got to understand garbage in, garbage out for AI. We've got to understand that for machine learning and AI. So for example, if we're training our machine learning and AI algorithms based off of biased data, those algorithms will give you biased results. Okay? And so that's why I say we have to be very disciplined about how we use these tools. We have to factor in bias, addressing disparities, focus on equity. Those all have to be built in. So again, language preference is one of those standard ones, right? Where you build let's say you build an app, because everyone loves apps. I'm not as huge a fan of apps, but everyone loves apps, right? Let's say you build an app, wonderful app. Let's say you can schedule your appointments, and you can email or you can text your doc on the app, or all these kinds of things. That sounds wonderful, right? What if English is not your first language? And what if we decide, like the airlines did, for example, that the old ways of how you communicate with us are no longer, we're going to make those really hard for you, right? Remember we used to be able to call the airline and schedule, and get a flight, right? That used to happen. Try to do that now. They've decided that those old ways of communication and interaction and engagement, they're not going to do that. So what if we decide, wow, this app that you just created is so good, we're going to have fewer telephone operators now. We're just not going to. Certainly everyone should interact through the app. But you did not design the app in a way that addresses, literacy, language preference, any other, you just built an app that you thought was really cool because that's what they do in digital. That's where you are inherently exacerbating disparities, and you may not even realize that's what you did. Mm-hmm. That to me, that's where we have to be disciplined, and it has to be front and center. Otherwise, the outcome is already known. It's not good.
Isn't that good? And speaking of training, so I know you do some teaching with residents, right?
Yes.
And I think that's another question that we all have is how to make sure we are training the trainees in a way that they're going to be at least more sensitive to these issues. So I mean, I remember going through even med school, we touched on these things, briefly, maybe a lecture here or
Yeah.
there. And so unless you were personally interested in the topic, then you could go through your whole training and not have much sensitivity to health disparities or any type of inequities in medicine. So you have any thoughts on how we can better incorporate that into medical training or any
Yeah,
training?
so any training really, yeah, you're right. I thinking about that, I was lucky in my training as well. So like you said, maybe you had a lecture here or there. I was lucky in my training at UCLA where I had really great teachers and mentors. Billy Cunningham, who passed away recently, was one of mine. Really inspiring. David Carlisle, who's now the president at Drew, at Charles R. Drew, another one that just inspired me to think bigger picture. Because because in your med school, you're thinking about physiology and pathophys and anatomy. You're just trying to stay above water in some ways. Yeah. Right? And then, then Dr. Carlisle comes back and says, hey, there's a whole world out there. Look at it. It's big. And there's haves and haves not out there from a healthcare perspective and understand what that means. And so, but we shouldn't rely on education on heroes like Drs. Cunningham and Carlisle. The education that we need to address disparity should be baked in to the structure of the curriculum. Right? If you think about digital and the interface between digital and health equity in this instance, there's a couple of assumptions there in the education piece, which you've already started to address, which is one, that anyone's getting any education on health equity, and two, that they're getting any education in digital, by the way. I'm not sure that's actually, I'm pretty sure that's not happening consistently. Yeah. Right? And so if you don't have either one of those, you're not going to be able to understand the intersection between the two. Right? And so I think it's time. I mean, the University of California recently just said, we're just going to do away with ACTs and SATs for undergrad assessment. Right. It just came out. So if they can do that, and that's a huge deal. I remember having to take that one because I went to a UCU undergrad. And if we can do that, I think that medical education, if we start there, I think public health probably does a much better job than we did in medical education. Let's rethink the curriculum. Let's really rethink the curriculum. One of the things I learned is when I talked earlier about the themes from my sabbatical, one of them was actually education. I learned a ton from a medical school down in Plymouth in the southwest part of the UK. And what they decided to do in rethinking the curriculum was they said, you know what? Do we need a bunch of doctors who know how to memorize stuff? Is that important anymore? Maybe it was important 20 years ago, 30 years ago. Is it still important? Memorizing every single bone of the hand? In less than 30 seconds, I can pull up a picture of every single bone of the hand. So do you have to memorize that if you're not a hand surgeon? Right? That's the point. So why are we still focused on rote memorization and then rote regurgitation of that memorization in our high stakes exams? And why aren't we focusing more on, interpersonal communication, leadership, equity, those things that truly will make a difference to those that we serve? I think it's time to really revamp the curriculum, and that's not an easy thing. And in some ways, the tail wags the dog, right? As you got these high stakes exams. So if you decide to change the curriculum around, but they're not prepared for that high stakes exam, and they all fail because those exams still old, right? So it's the tail's wagging the dog. The exam is supposed to examine whether or not you know what you need to do to be a physician, but it's slow to change. Right. And so I think there's a big challenge there in the educational piece, and And, again, I think we start building in, equity should have been a core component from the very beginning. Let's just full stop on that. But I think increasingly the tools and techniques that we will be using as physicians and other clinicians, the tools and techniques we will be using in the future need to be at least introduced in some way, shape, or form earlier on in education. And again, I think digital is one of those.
That I agree with you, and I think it'll come. I think we are evolving. I do think it's part of this COVID response is that everything has had to change because we didn't have a choice, right? Mm-hmm. And so I think that has increased our innovation and creativity and those type of things, and highlighted that the way that we don't have to keep doing the things the way we were doing them. This is an opportunity to change. And so it's I guess one of the good things that has happened. But that being said, it also is highlighted, a lot of inequities and disparities in our system. And, I feel like we should talk briefly about it. I don't want to talk extensively, but any specific thoughts around the COVID-19 pandemic and inequities and disparities and digital health? You can pick one of any of them.
Yeah, there's there's a lot in that question.
I know, sorry.
Okay. Let's talk about, because the first part of the stem for your question was things have changed fairly rapidly, for good reason, in light of the pandemic. What's amazing, so for example, I'll take Moffitt as an example. A couple big things happened for us, right? And my team was one of the key support structures for both of these. So one, as I think I mentioned earlier, over half of our team members working from home. We would have a few hundred, maybe a couple hundred. We have 7,000 total, plus or minus. And over half working from home. That was a heavy lift. And it happened, we're talking a couple of weeks, not, it just happened quickly, right? So you think about it, we take care of patients. So there's certain folks that cannot work from home. You got to go take care of a patient. So having over half of folks work from home, essentially everybody who could possibly work from home is working from home. You think of it that way. At the same time, literally in parallel, we increased our virtual visits by 5,000% plus. At its height, it might have gone up by 7,000%. I saw some of those numbers. Literally 50x volume in our virtual visits. And for safety reasons, and for lots of reasons, all the reasons that why you would do a virtual visit versus having someone come in. But guess what happened when we did that? And maybe that number may come down a little bit and adjust based off of how we come back from the recovery from the pandemic, once we ever recover from the pandemic. But what that showed was a couple of things, and they're actually groundbreaking insights. So on the first point, we said, wait a minute, if 50+% of our folks can work from home, should they ever come back? Now, a certain percent, yes, of course, or maybe there's some kind of rotating model, or there's some, there's all kind of different ways to think about it, but think about how that changes your approach to space planning, for example, and your approach to capital allocation if folks can work from home. So that's one. On the virtual side, wait a minute, we just went from a couple hundred visits to thousands of visits a week. And guess what? The docs were okay with it. The advanced practice providers, the physicians, they said, this is not that bad, actually. We can do this. Some docs came to me, and I won't call them out by name, but they said, you know what? I can do all my visits like this. 100%. And others said, I really need to be able to physically examine a patient, which completely is understandable. So the docs are on board, and the advanced practice providers are on board. Guess what? The patients were always on board. They were waiting for us to figure it out. So those are really great insights. That allows you to really rethink how you deliver that care. But did we leave a group out? What about people who may not have access to high-speed Wi-Fi? You really need strong Wi-Fi, right? If you're going to be doing a video visit. What if folks don't have that? Do we need to think about we need to think about how do you engage with those folks? What are now you're starting thinking about public health. What are the public health interventions potentially? Do you set up, one thing I always wanted to do, I wasn't able to quite figure out how to pull it off, but I just wanted to provide free high-speed Wi-Fi for like an entire community. Just give it Wi-Fi for everybody. You don't have to worry about it, right? Because the other solutions are, let's figure out how to give them an iPad with an account, or let's set up, just give Wi-Fi to everybody. At this point, it's just a public health intervention,
right?
And so that's one. But yes, it did address it did bring up that issue, and made it more prominent perhaps. There's a couple of things, Dr. Fleming, that I wanted to bring up though in terms of the impact of COVID. One is the role of the payers, public and private. Right. So CMS said, you know what, we're just going to decrease a lot of the red tape and allow you guys to go out there and take care of patients virtually. Guess what? Why would that red tape ever come back? Why would you do that? It's been very clear that this is the way we should take care of patients when appropriate, clinically.
Right.
Why would you, think about, cause I worked with, I think about your specialty, and I worked with the chair of our of a OBGYN department, and we talked about prenatal visits, and we said, let's be honest, how many really need to be in person? Let's be real honest. You've got whatever labs you might need or whatever. You've got all that quantitative data. How many really need to be in person? Anything that does not need to be in person, don't make it in person. And let's figure out how to do that, right? That, to me, those are really the question. It's not necessarily that. To me, it's everything that should not be in person, everything that doesn't absolutely require in-person visits should be done virtually. That's my approach on things. And I get it. Some of the other folks are saying the other approach would be, what are the visits that really that are okay to be virtual? And they'll go in and pick out one here, one there, one there. I have the different view, right? Tell me all the visits that need to be in person, and then everything else is virtual. And they're different, and you're going to come to different conclusions, by the way, even though it seems like it's the same question. And then there's something that I thought really, really fascinating. As you know, healthcare systems are often slow to make decisions. Not in these times. Right? There's this idea that there's a rapid assessment of any potential innovation or solution that will get us what we need in terms of how we, being able to take care of patients and fulfill our mission. And we'll see an opportunity, assess it, and make a go, no-go decision in record time. I've never seen anything like it before.
Much different.
And so to me, that was really, really impressive. For example, and I'll shout Zoom out. So we made a decision to have all of our clinical visits, our virtual visits, on Zoom. And we made that decision, the operational team made the decision, not the IT team, made that decision, I think, in less than a week. They were just like, you know what, we're just going to go all Zoom. They went back to IT and said, can we do all Zoom? Yeah, we can do it. Security, I know there's some issues about security. Those things were figured out pretty quickly. There's some standard things you got to do. There's some automatic things you want to make sure happen. From a security perspective, passwords, all that, all Zoom. Decision was made like that. Can't imagine that being, if you don't have the pressure of a pandemic, you don't make that decision that quickly. I'm not sure we'd still be talking about it.
Yes, there'd be some task force or some strategic planning.
Exactly. There'd be a committee for a task force, or exactly, you know how this works. And so, that to me was really, 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 really impressive. And the last point I want to say on the COVID thing is, which it was interesting because I don't think people are pointing this out as much. What I'm finding is that there's actually an increased emphasis on leveraging digital to find operational efficiencies. Now, why would COVID have anything to do with that? Well, because health systems and cancer centers are struggling financially because of COVID, right? You've got a lot of folks who are just staying at home and just afraid to come in, and and that's so your top line revenue is taking a hit across the board. Everyone's top line revenue is taking a hit.
Exactly.
So if you can't increase that directly, then you've got to find a way to decrease your expenses. And how can you? So again, you say, wait a minute, are there digital tools that can help us decrease our expenses, be more efficient, be more effective at what we do, and with fewer resources? And so I've been really pleasantly surprised by the emphasis on finding operational efficiencies leveraging digital tools.
Thank you. That was, I think you left us with a lot to think about. And so typically, because I was thinking, typically how I like to close these is, what has been your biggest challenge during the pandemic, and what do you hope that we collectively learn on the other side of that? I'm still gonna let you answer it, but I also think you gave, more of a robust answer than I would have typically gotten out of asking those questions anyway. But and specifically to one of your points about prenatal care, I've been thinking about that a lot. And when we first started transitioning to the telehealth visits, I was like, prenatal care is going to be forever changed, and it needs to be. And I think it's an antiquated system. But I mean, and to that specific example, we just have to make sure that we're not leaving our ladies out who don't have access to reliable mobile technology or computer technology and that type of thing. And so I think but again, now that we know that we can change things at a quicker pace, I think it can be done, it has to be done, and it will be done. And I think we can do it in a fair and equitable way as long as we think about it. But anywho, as we close, because I know you have so many other things to do today, any thoughts on that as far as, your personal challenges, and what, if one thing, if we come out of this better, one thing, what would you think you'd like to see?
I think, so you're right. I've mentioned a lot of I should have probably saved my thing to the end so I can answer the question. But I think one thing, if I was to summarize it all up, I would say, the challenge and the opportunity is to not think of digital as a nice to have. At this point, it's critical to the success of your mission if your mission is to improve health in any way, shape, or form. It's critical to your mission. And so it's not an afterthought. It has to be built and baked into how you are going to execute on that mission. And as you do that, and as you leverage those tools, back to our earlier point from earlier in the conversation, make sure that you are disciplined and focused on addressing disparities and leveraging the importance of health equity as you build out those tools. I think that would be my opportunity there.
I like it. I think that is a great place for us to close. I like to close with a little bit of optimism. We get a little heavy in the middle, so got to bring it back up a little bit. But thank you for joining us. I appreciate the conversation. I'm looking forward to seeing and following your career at Moffitt and all the exciting things that you'll be doing there. So congratulations again on the new position, and look forward to seeing what new and exciting things you do next.
Thanks, Dr. Fleming, and thanks to the Reed Scholars. Appreciate it.
Thank you for listening to Reed Scholars Live. Please follow us on Facebook, Twitter, or Instagram, or subscribe to our YouTube channel.